Hi, this is Dr. Sherry Shabowski from Medical Education in Minutes. And I know I usually do short videos, but this one's a little longer. This is a big guy. This is blood type and transfusion reactions. So let's get started. Meet the red blood cells. There are four types of blood, but only two antigens on the red cell membrane for type. The blood type antigens are represented as hats here. Type O would be better identified as type 0 or not because it occurs when there is no type antigen. Here, we call type O naked, which it is as far as type antigens go. Then there is type A and type B, and the combination of those two antigens, which is type AB. This is how only two type antigens can make up four blood types. Now, here's something that is not intuitive, at least to me. Your body has pre existing antibodies to the antigen or type that you do not possess. So, for instance, our naked type naught has no antigen on its surface. So, it has antibodies to type A and type B. Someone with type AB antigen has both antigens. So it makes no type-specific antibodies at all. Type B has antibodies to type A, and type A has antibodies to type B. So far, so good. The rest is going to build on these concepts. So if you didn't quite catch this, re-listen. It'll be important. So here's type A and type B blood. These guys get two hats. It is a question of genotype versus phenotype. Genotype is the genetic makeup of inherited alleles. Phenotype is what you look like or outwardly express based on your genetics. Alleles can be homozygous dominant, like big B, or heterozygous, B naught. Both of these will express themselves as type B blood. I know that I am type AO or A naught or heterozygous A. Now, how do I know this? Well, this is called a Punnett square, which is a 2x2 allele chart. It is a simple grid used to predict the possible genotypes and phenotypes of offspring from a genetic cross. Now, assuming my parents are my parents and that they accurately told me their blood type, yeah, that sentence might seem like it's not important, but to avoid errors, it is best to critically evaluate possible errors that you are making in your analytics before you make a decision. Okay, so up top is my mom. My mom was type O. This guarantees that she was homozygous O or not. Both alleles are not or absent type antigen, or she would have been another blood type. My dad was type A, and I am type A. Even if my father was homozygous AA, when his alleles combined with my mother's alleles, you get A naught or heterozygous A every time. So that's how I know. Okay, try it yourself and figure out how a heterozygous type A or A naught and a heterozygous type B or B naught can make all the blood types. Pause if needed. Yep, every single one. A, B, and O. Maybe you would not think that an AB and an AB would make all ABs. But no, it's just half. I think you're getting the picture. Practice a little bit if you're not crystal clear here. The circles in the picture represent your B cells, and these are, of course, part of your adaptive immune system. B cells make antibodies against specific antigens. This picture denotes a red blood cell with both antigens, A and B. Neither are foreign to your immune system or the B cells. So the B cell will not make any antibodies to attack either antigen. Ready to make a jump? Since the person who is type A and type B alleles and therefore makes no type of antibodies, a person who is type AB can receive blood from all types, and the immune system will not react. He doesn't have antibodies to type. People who are type AB are universal recipients of blood and can receive blood from any blood type, which is either great luck or great design because only 2% of the US population is type AB, and they would have a lot of trouble getting a transfusion if they had to have type AB. Now let's consider someone who is type A. I'm type B, perhaps it's me. My immune system knows the type A antigen is ours. But since we are not type B, the immune system will make antibodies to type B. And again, remember, these are pre-existent. They've been in me, these type B antibodies have been in me my whole life. So someone who is type A can get transfusions from someone who is type A or someone who has no antigen at all. That would be someone who is type O. You see these other two guys, the AB and the B, they're getting whacked. Type B only loves red hats, or type B antigen, and mounts a defense against type A antigen. Red is anti-blue, so you cannot introduce any blue. So type A blood, if it were transfused, or type AB blood, if it were to be transfused, would be destroyed. But this guy is fine getting type A blood or type O. Type O has no antigen, so it has extra antibodies against type A and type B from birth. It is naked. It can only surround itself with other naked cells. Nothing but destruction will occur if you try to transfuse with any other blood type. So naked can only accept naked or type O. Again, luck or good design? I mean, it works out because 50% of people are type O. It is the most common blood type. Now, you may or may not have noticed as we have moved along here that type O blood was okay to be transfused to every blood type. The lack of antigen means no one has antibodies to type O. So type O is the universal donor for all blood types. Again, it works out great because statistically, half of your donors will be type O. All right, this is a person with the naked type O blood who is accidentally given a type A blood transfusion. The type O person already has pre-existing anti-A and anti-B antibodies at the ready. These pre-existing antibodies are a key difference between ABO type incompatibility and RH factor incompatibility. But we will get to that. So what happens when this blood is introduced to the type O person? The antibodies quickly attach to the type A antigen. The red cell is opsonized with antibodies and the complement cascade is triggered, ultimately resulting in cytolysis or hemolysis, might be a better word in this case. The explosive destruction of the type A red cells can lead to anemia. When the type A antibodies explode, the LDH, which has a very high concentration within the red cells, escapes into the blood and can be measured. So you might see in someone who has hemolysis a high LDH. Free hemoglobin is released into the blood. And honestly, free hemoglobin is not great. So luckily, your liver makes haptoglobin, and it's always in your circulation. That haptoglobin will combine with hemoglobin. Hemoglobin attached to haptoglobin is less dangerous than free hemoglobin. Again, haptoglobin is made in the liver and circulates in the blood. And it is a great thing because it picks up the free hemoglobin released from hemolysis of red cells and makes a complex that is so big that it can't be filtered into the kidneys. In fact, it gets eaten up by macrophages. In this picture, I'm making it look like it's being eaten up by macrophages in the spleen and broken down into its key components, hemoglobin and iron. Notice that bilirubin is released into the blood. And this is why when patients have hemolysis, they can become jaundiced. Thank goodness for haptoglobin, because free hemoglobin is very dangerous to the proximal tubules in the kidney. Free hemoglobin readily undergoes oxidation, which generates reactive oxygen species and also releases highly reactive heme. This highly reactive heme damages lipids, proteins, and DNA and disrupts mitochondrial function in the proximal tubule cells. The free heme is a potent pro-inflammatory and pro-oxidant molecule that causes cell injury. Heme also competes for protein uptake in the proximal tubules. Therefore, the reabsorption of other proteins can be blocked. Finally, in severe cases, high concentrations of free hemoglobin in the renal proximal tubules can precipitate and form hemoglobin casts, physically obstructing the flow of filtrate and contributing to acute kidney injury or acute tubular necrosis. The final result is acute tubular necrosis and potentially complete renal failure. It should be known also that the urine in this case, when there's hemoglobin or free hemoglobin within it, will turn a brown color. This can be a clue that you have a hemolytic reaction. This should be emphasized that a person is having symptoms of a transfusion reaction. You need to stop the transfusion immediately, especially if you believe it to be hemolytic. If only a little unmatched blood got in, the haptoglobin might be able to trap the free hemoglobin and minimize the damage to the kidneys. But if you get the full transfusion, you're going to get into trouble. The hemolysis of the abnormal type blood will result in a complement cascade, an inflammatory response, which is triggered by that antigen antibody interaction. This also leads to increased permeability in the capillary beds and edema into the tissues. If there's enough fluid in the tissues, that means you will decrease intravascular volume, and this may lead to vascular collapse. This is an overview slide of the hemolytic transfusion incompatibility reaction. The person will have symptoms, including fever, chills, flank pain, which makes sense because the kidneys are really a big part of this. Brown urine, also showing that heme is going into the proximal tubules. The patient is jaundiced because there's hemolysis, and they get an overall feeling of doom. That may be because a lot of these people die. They have tachycardia, edema, they can wind up with acute renal failure, hypotension, vascular collapse, a disseminated intravascular coagulation, and organ failure. Things that might tip you off to that this is going on is a pretty severe anemia. You'll see a high LDH on blood tests and a low haptoglobin. Again, the circulating haptoglobin is now combined with free hemoglobin, so therefore less circulating. And then you'll have a positive Coombs test, which is what happens when the antigen antibodies come together, the red blood cells will clump. And this gives you the idea that you have a hemolytic transfusion incompatibility reaction. Fatality rates for ABO incompatible transfusions is 6 to 17%. And there's some basis to show that the severity is a result of the speed and volume of transfused blood. Human error is the greatest risk factor for transfusion reactions such as these. I mean, they're getting the wrong blood type. So mind all the cross checks that are necessary for safe transfusion and be sure to monitor your patient closely. In fact, so much is done in the hospital to avoid this error that it is, in fact, very uncommon. Thank goodness. But there are other other transfusion reactions that need to be considered. Here's an overview slide of the different types of transfusion reactions, but we will discuss them separately. ABO incompatibility, hemolytic disease of newborns. So, let's say someone has a type O mother, like mine, and she gives birth to a type A child, like me. There is a possibility that the mother's anti-A IgG antibodies may cross the placenta and attack the baby's blood cells. In fact, this occurs in 15% of pregnancies. But the exposure is usually small volume, and the symptoms are usually mild. The child may have anemia. They may have some jaundice, which usually responds nicely to phototherapy. In more severe cases, you may see poor feeding or hepatosplenomegaly. But luckily, fetal red blood cells have fewer AB antigens and different hemoglobin, making the hemolytic reaction typically mild. I did fine. Most people have an Rh antigen on their blood cells. Some do not. Now, Rh is a bit different than the ABO antigen. First, there are 5 different Rh antigens, with D being the most clinically relevant. Second, people who are Rh negative do not have pre-existing circulating anti-Rh antibodies. They are only made in response to an exposure. This is the primary difference from ABO incompatibility. We've gone a ways here. Let's have a quiz. Okay. My parents are both Rh positive, and I am Rh negative. Am I adopted? Rh is dominant, so parents may both be heterozygotes. Can you fill in the Punnett square here and find out if the person is actually clearly adopted? As it turns out, if 2 heterozygote Rh positive people mate and produce offspring, 50% of them will be Rh positive not, 25% will be Rh positive dominant, and 25% will be not or Rh negative. Good thing. No worries. Your parents are, at least from this test, most likely to be your parents. All right. So what happens if an Rh negative mom has an Rh positive fetus because the dad was positive? Well, the mom begins with no antibodies to Rh positive child at all. And the placenta forms a barrier between the maternal and fetal blood supplies. So they really shouldn't mix. But there are certain situations where the mother and child's blood may mix, including at the time of delivery, abdominal trauma, miscarriages, especially later miscarriages, invasive procedures like amniocentesis, and then there's something called microchimeric, which means that sometimes a little blood can just cross over. This crossing sensitizes the mom, who will now make antibodies to the Rh factor. No big deal for this particular pregnancy typically, but it may be problematic in subsequent pregnancies, as we will see. The good news is that now we have something called ROGAM. ROGAM provides anti-Rh antibodies at the time of exposure. They're ready-made and injected antibodies that surround the Rh antigen, so the mother is never sensitized. When an Rh negative woman is pregnant, she'll typically get ROGAM at 28 weeks and then hopefully also planned ahead 72 hours before delivery. Here's a little Rh positive baby blood in mom's circulation. Not great. This could cause a problem. But here we're giving pre-made antibodies to Rh or ROGAM to the mom. These antibodies will cling to the Rh positive blood and shield the Rh factor from the mom's immune system, keeping her from becoming sensitized. How cool is that? And not only cool, super important, because on the next slide, we're going to see what happens when ROGAM is not given and an Rh negative mom who had an Rh positive baby gets pregnant again. This is called erythroblastosis fetalis. And fetalis is baby, but it's also deadly. It can also be called the hemolytic disease of newborns, where children can come out quite jaundiced. And it can be so severe that bilirubin actually affects the brain and causes long-term damage to the brain. The child may be born lethargic with low muscle tone. The child is likely to be born with severe anemia, heart strain, fluid buildup in the organs, hepatosplenomegaly. The survival for another Rh positive child inside of an Rh negative mother is going to be less than 50%. I mean, now they can do things like interuterine attempts to improve outcome if you know what's going on here. And of course, ROGAM is used for prevention of this horrible hemolytic reaction. Here's a big one. In emergency situations only, let's be clear on that. We are currently talking about a transfusion in a person that would otherwise die without it. In those cases, transfusion may need to be started before the person's blood type is known. In childbearing years, women get O negative blood emergently, but postmenopausal women and men get O positive blood, even if we don't know if they are Rh negative. If Rh negative, subsequent transfusions, if the person happened to need another emergent transfusion again with O positive, could result in a hemolytic transfusion reaction that could lead to death. If this is a risk, doesn't everyone get O negative blood in an emergency? Well, medical decision making can be very complex, and this clinical question illustrates it better than most. Let's start here. What are the odds that any given person is Rh negative? Well, in the US, about 25% of people are Rh negative, so it's not inconsequential. Here's another thought. What are the odds that anyone you know will get uncross-matched blood in their lifetime? Well, less than 1% of all patients admitted to the hospital, and again, these are the ones that are most likely to get transfused. Less than 1% of all patients admitted to the hospital will get uncross-matched blood. So it doesn't happen very often. What are the odds that a male or postmenopausal female will get a subsequent uncross-matched transfusion, meaning on two separate occasions in their lifetime? I would argue this is so much less than lightning striking in the same place twice. In fact, that happens kind of often. But this is a very improbable event. Now, what is the availability of O negative blood compared to O positive blood? Well, presuming there's a normal distribution across people who donate blood, 36% of the population is O positive and 14% are O negative. So the availability is going to be a bit less. O blood is essential since an ABO mismatch is potentially acutely deadly. Rh mismatch will not cause immediate complications if the person was not previously sensitized. Or, in very special and improbable circumstances, if given O positive uncross matched blood again in an emergency in the future, it could lead to a transfusion reaction. Again, 2 emergent transfusions of uncross matched blood in a lifetime? Extremely unlikely. Now, timing is a big issue here. It takes 5 to 15 minutes, depending on your lab, to get type specific blood, meaning blood that is ABO and RH compatible. I would argue there is a rare circumstance where you cannot wait for type specific blood. But in order to make this work, you're going to have to be thinking ahead and preparing. There are several things needed to acquire that type specific blood promptly. Often, you need a phlebotomist who needs to draw and label the blood. The reason why this is critical is we want to avoid human error, because human error is typically what leads to ABO incompatible transfusion problems, and we don't want that. Next, you need to get that blood from being drawn and labeled to the actual lab. Then the blood bank needs to be alerted that you need type specific blood quickly so that they can prepare the test immediately when the blood gets there. And to make it faster, you may actually need to go get the blood from the blood bank. There are a few cross checks that need to be done before a blood transfusion that cannot be rushed in the clinical area. So, realistically, it may take around 40 minutes from order to beginning the transfusion of type specific blood, even in the best of circumstances. Just for reference, it takes about 45 minutes to 2 hours for a complete type and screen to be done, with antibody screening in addition to ABO and rhesus factor checked. So, truly getting type and cross blood can take a long time. And if someone's bleeding to death, you don't want them waiting that many hours, right? O positive and O negative uncross matched blood in most hospitals can be transfused within 15 minutes. But there is frequently a limited supply. Therefore, the choice to use O positive in men and older women makes some sense, even though there may be some long term risk associated with making that choice. It is for this reason that people who are likely to hemorrhage again or get frequent transfusions should really be considered for O negative, even if they're men or older women. If an Rh negative patient gets Rh positive blood in an emergency, the doctor could say something like, "We saved your life, but in the future, you're going to need to only get Rh negative blood no matter what the circumstance." We recommend a medical alert band in these situations. The take home message here is this: you can typically get type specific blood into your patient within a reasonably short period of time as long as everything runs smoothly. So you don't have to give people uncross matched blood very often. However, if the patient is going to die without it, you need to act. For me, I find that if I tell the lab that I need uncross matched blood or type specific blood within 30 minutes, it's amazing how often I can get type specific blood. Might want to use that technique in your future. As it turns out, it is very lucky that type O can be given to almost every person because it is the most common blood type. AB, on the other hand, is very uncommon. So it's also very lucky that they can take blood from almost any blood type. In fact, any blood type. Type B is a little more difficult since they can only get B or O, and B is really uncommon. Again, thank goodness that O is the most common. It is almost as if our Creator planned for transfusions when he or she made us. Now that's forethought. Now let's discuss the other possible transfusion reactions, because there's a lot more. And God willing, ABO incompatibility will never come up in your career. Let's start with the allergic transfusion reaction, or ATR. This is the most common transfusion reaction. It is a type 1 hypersensitivity reaction and occurs in 1 to 3% of transfusions. It's an allergy to plasma proteins in the donor's blood. So, in fact, the person is not allergic to the red cells. Here's a crazy thing that you might want to stick in the back of your head for testing purposes and possibly to avoid problems in the future. People with AGA deficiency are at significantly increased risk for allergic transfusion reactions. And their allergic transfusion reactions tend to be severe. So keep it in mind. This is why you do a past medical history on your patients. Symptoms of this allergic transfusion reaction range from itching to urticaria to anaphylaxis. Of all the allergic transfusion reactions, 0.7 to 10% will result in anaphylaxis. Now, that may seem like a lot, but it's literally a small proportion of a very small proportion of people who get this. So, in fact, it's rare. You may want to know that allergic transfusion reactions are 10 times more common when transfusing platelets or plasma rather than packed red blood cells. The treatment, it's almost universal that you can give these patients H2 blockers like diphenhydramine, and the problem resolves completely, and you can continue the transfusion. In more severe reactions, you may require steroids, and in the most severe reactions, you may require epinephrine. But luckily, again, the severe allergic transfusion reaction is very uncommon. Here's another common transfusion reaction. In fact, it occurs in 1% of all transfusions. And anybody who's been transfusing people for a while has seen this happen. It's common. This is the febrile transfusion reaction. I don't know if you know this, but packed red blood cells is a misnomer because it's not just packed red cells. Even when they leukoreduce and filter the packed red blood cells on purpose to get rid of the white cells, some white cells and platelets still slip into the packed red blood cells. Febrile transfusion reactions are a type 2 hypersensitivity reaction. The host's antibodies are against the donor's white blood cells and cytokines that are in the stored blood. This triggers the release of cytokines, which increase symptoms, causing fever and chills, the most common symptom by far. You may also see flushing and headache. This is not uncommon, but there is no hemolysis. This is a very important distinction. The treatment is to stop transfusion until you know exactly what's going on. We will give acetaminophen for the fever and then check to make sure that we're certain that there's no evidence of hemolysis. Once you're sure that everything's okay and the patient is doing well and it was just a fever, no big deal, you may consider starting that transfusion again. Now let's talk TRALI, or transfusion-related acute lung injury. This is a situation where you have non-cardiogenic pulmonary edema. In this case, the donor's anti-leukocyte antibodies attack lung endothelial cells. The predisposition for this disease is typically that the person already has a problem with the lungs or some form of inflammation in the lungs or a severe illness. This happens in 1 in 5,000 units of packed red blood cells that are transfused. And it is less common with transfusion of other blood products. It is, however, responsible for 30% of transfusion-related deaths. The symptoms include acute dyspnea, hypoxemia, fever, hypotension, tachycardia, leukopenia, thrombocytopenia. And here's the tough part. Treatment is prevention and improved oxygenation. Not a lot we can do to fix this problem. You may be tempted to give diuretics because the lungs are full of fluid, but this would not be correct. This situation is a little more like ARDS, and taking away fluids is just going to cause more problems. It can occur during or after transfusion. I count myself lucky. I have never seen a patient with trolley. So there are two different situations where a transfusion can lead to a person becoming very short of breath with pulmonary edema. Trolley and taco. So now let's talk taco. Taco is transfusion-associated circulatory overload. It is typically caused by giving too much volume too fast in a vulnerable patient. So for instance, someone with heart disease already, or heart failure, someone with renal disease who can't clear fluid, someone with liver failure, the elderly, the critically ill, or infants. In this case, the treatment is to stop the transfusion and give diuretics. In this case, you actually do want to diurese the patient and decrease the volume. Again, the problem was overload. Now, you could see how it wouldn't be necessarily obvious which one was going on if you're transfusing a patient and all of a sudden they get pulmonary edema. You would consider using the bedside cardiac ultrasound to distinguish how the heart is functioning, because this may give you a good idea of which problem you're dealing with. And since the treatment is different, it's going to be important that you know. This is not a transfusion reaction per se, but don't forget, a lot of these situations result in a fever. Fever is not an uncommon transfusion reaction. But we also need to consider the possibility that the person getting the transfusion might be septic or their fever might be from an infection. Blood, in fact, is a perfect medium for bacterial growth. The risk of bacterial growth in packed red blood cells left out too long before transfusion starts to go up pretty quickly. Packed red blood cells must typically start within 30 minutes of leaving the blood bank and should be finished within 4 hours. Just remember, there is a differential diagnosis for fever, and you got to consider other things even if the fever comes when the transfusion is going on. I know, that's a lot, but let's review what we learned today. Okay, there are only two blood type antigens, A and B, but there are four blood types, A, B, AB, and not, or naked, or type O. People have pre-existing antibodies to other type antigens. Rh negative is rare. 25% or less of the population are Rh negative. they have no pre-existing antibodies to Rh. In order to have a problem, it requires sensitization for that reaction. And we have learned that ROGAM is preventative so that people are not sensitized. Let's review a few of the transfusion reactions. Remember, allergic transfusion reaction is common. It's a reaction to proteins in the blood. Typically very mild, H2 blockers alone and continue the transfusion is usually how it goes. But in situations where you have patients who are IgA deficient, the allergic reaction can be much worse. Febrile non-hemolytic transfusion reactions. Note, I bolded non-hemolytic because that is critical to distinguish here. This one is very common. You have host antibodies to the transfusion white blood cells or white blood cells within the transfused blood. The most common features are fever and chills, most often during the transfusion. Stop the transfusion, give the patient Tylenol, check for hemolysis, and make sure you don't have another problem. No hemolysis? After a bit, if you're comfortable with that, continue the transfusion. Hemolytic transfusion reaction. Thank God this is uncommon. It means you got the wrong blood type or Rh factor. This results in hemolysis, both intra and extravascular. Free hemoglobin is generated, and you wind up with symptoms like severe anemia, acute tubular necrosis, jaundice, flank pain, dark urine, organ failure. This is the big kahuna. Hopefully, you will never see this in your career. But remember, you can see this in the hemolysis of the neonate when a little bit of the mother's blood mixes with the baby's. Again, when it occurs in this situation, it won't be as severe because fetal hemoglobin is a bit different. But this is the ABO incompatibility you're most likely to see, especially if you're careful. Trolley, uncommon, luckily. Typically occurs in the very ill, elderly, and babies, and often in people with pre-existing lung inflammation. This is non-cardiogenic pulmonary edema, much like ARDS. It has a high mortality, and you don't want to diurese. And finally, TACO. This is cardiogenic pulmonary edema because fluid has been transfused too fast and too much in someone who just can't handle it. The answer to this one is, in fact, diuresis. And a bedside cardiac ultrasound can help you to distinguish between the two. TACO is actually reasonably common. All right. Thank you so much for learning with me today. I know this one was a little bit long. Sorry for that. This one is huge. I hope that you now have a better understanding of blood types and transfusion reactions so you can take the best care of your patients. And if you have an opportunity, check out the video courses at www.medicaleducationinminutes.com. And please like, subscribe, and comment to Medical Education in Minutes on YouTube. See you next time.